This is a Memorial Day weekend, and I would like to just take a small, quick moment of silence, if that's okay, for us to just remember and reflect, and for us to think of all of the people that we have in our hearts, who've gone on before us. So if we could just take that moment together, please. And thank you all. Thank you so very much. God bless every one of you. And Dr. Tennant, we'll go ahead and turn the show right over to you. We've missed you all. It's great to see you. Thank you.
Yes, thank you, Jamie. We've had a couple of weeks off for vacation, and we're back, and we're going to have a very good show today. We're going to continue to explore the attitude of the American public and how the public feels about pain, opioids, and about the problems that we face today. I've asked Jamie also to read something in a little while that is very profound about how the public feels about where we're at today in trying to help the pained and suffering person. To get us started, I'm going to talk about something that sounds like we should have known this all along. And all of you know that we've had a real effort to understand the disease of adhesive arachnoiditis. Now, when we got started with this project about 8 years ago, it might surprise you to know or that we really didn't know what the arachnoid was. So we're going to spend a few minutes talking about what is technically known as the arachnoid membrane. In some ways, this lack of information or lack of knowledge about this membrane has kept us from understanding a lot of things that affect all of us as patients or as practitioners. Now, I'm not going to ask, but if I did ask all of you, what is the arachnoid membrane, you might tell me it has something to do with the brain or the spinal cord. It has a lot to do with pain, but you probably really don't know what it is. Well, we're going to talk about that because now that we understand the arachnoid membrane, we've been able to move forward. Let me challenge you with this to start with. It turns out, in my opinion, what we call failback surgery syndrome, what we call degenerative spine disease, or we call it polyneuropathy, something like that, or even sciatica, probably is arachnoiditis. Okay? Now, first off, what is the arachnoid membrane? Well, now, a membrane kind of tells you that it's real thin and it's very fragile. Now, that describes membranes. Now, we have membranes throughout the body. We have them right in our mouth. We have a coating over our throat and mouth. And so membranes are everywhere. Now, the arachnoid membrane, first off, and to illustrate what it is, I'm going to show you a prop here today that you're all familiar with. Okay? I want you to assume for a minute now this is the spinal cord, not a toilet paper wrap. The arachnoid membrane is actually a very thin little coating inside the spinal canal. Now, if you take this for a moment and just imagine that this is the spinal canal. Now, this outside tough layer is going to be called the dura. But right inside, against that, is the arachnoid membrane. Now, this is very interesting. This membrane goes all the way up your spinal cord and around your brain, and then back down the spinal canal. It is a closed net, if you will. It's like a net. It's called arachnoid because in the 1600s, I believe it was the Dutch, looked at this membrane under a microscope. They were crude microscopes, obviously, but they could see that it sort of resembled a spider's web. And that's why it was called the arachnoid, because it looked like it was a spider web, literally, that coated the inside of the spinal canal, and it went up over the head and the brain and back down. Now, what is the arachnoid made of? It's made of very thin fibers, and it's very protein bound. So it's very proteinaceous. It's like a very micro nerve, if you want to call it that. But the point is, it's wrapped around just inside the dura of the spinal canal. Now, one of the things you need to know about it, it's loaded with small nerves. When you touch that thing or you inflame that, boy, does it hurt. It's pain. So therefore, severe pain and arachnoiditis are what it's all about. Nobody really understood this. It might surprise you. This, in a way, is a little bit of a new finding because everybody thought that pain in the spinal cord was either muscle spasm or it was a compression on a nerve root, something like that. But the membrane, very thin, very fragile, made of protein, and lines the inside of the spinal canal. Now, what is it there for? We're not 100% certain. We know that it has a lot to do with supporting the dural structure. It has a lot to do with keeping, it's a network, it's net, okay? And so it holds things together. It holds things together. We know that it supplies some nutrients. It knows it has something to do with keeping the spinal fluid flow going, but it has a characteristic about it that is just a little shocking. It has no blood supply. Okay? No blood supply. Now, that has all kinds of ramifications clinically and for the patient and in what medications you're going to need for pain relief and for healing. Again, no blood supply. Now, today we have a reason for now realizing, what a big meaning this is. I don't know of another organ in the human body without a blood supply. Okay? And so it kind of borrows a little blood from the dura, but it primarily has to get its livelihood from the spinal fluid itself. And so with this tube, and it's vertical when it sits there, it's coated and spinal fluid is constantly soaking it. Okay? Soaking it. You don't have enough spinal fluid for some reason, you're not drinking enough fluids, you're not doing enough exercise, it's blocked, that arachnoid's going to hurt. Okay? It's got to be soaked in spinal fluid 24/7, 365 days a year. It is soaked constantly in a special fluid called spinal fluid. Now, I want to illustrate another thing for you. I've got a big coin here. Now, this is about the size of a disc, actually. Now, the spinal canal itself is only about the size of your index finger. It's very small, actually. But I want to show you about discs. These discs sit here in the vertebra. Now, if one gets degenerated and starts to slip, it'll come right into this canal and press upon this like this. Now, we used to think that slip discs all caused the pain because of pressing on a nerve. All it's got to do is press upon this canal and it'll hurt because it's pressing in the arachnoid membrane. Okay? So this idea that your doctor says, oh, you just got a couple of discs they're not really herniated yet, they're not too slipped, you don't need to operate yet. Well, they're slipped for some reason to start with, and they're pressing on the canal. I like the term protruding or pressing on the canal, because if it's pushing in on the arachnoid, you're going to have pain. You're also going to have some blockage of spinal fluid. I'll talk about that in a couple of minutes. Now, what we didn't know about the arachnoid was that it causes some clinical conditions that we really didn't know too much about. Now, one that some of you have or heard about is Tarloff cysts. Now, Tarloff is just the name of the man, but down in the very lower part of the spinal canal, if the arachnoid has a little deficiency, particularly like with a disease like Ehlers-Danlos syndrome or Marfan syndrome, osteogenesis imperfecta, or one of those collagen deficient diseases, the arachnoid is going to be affected. It is going to be weaker in people with EDS than it is in normal people. And so you're going to be very susceptible to cysts inside the spinal canal. In other words, a cyst inside the spinal canal, it may be called a Tarloff cyst, is really an outpouching or a weakness, a bubbling of the arachnoid membrane. Okay. Now, a cyst outside the spinal canal, I'm not going to talk about that because you need an expert on that, and we have some here in the United States who are experts and they know what they're doing. They're come from a different etiology or a different cause. Inside the spinal canal, cysts are an outpouching or a weakness in the arachnoid membrane. Now, another thing that happens, if the arachnoid membrane weakens in an area or gets inflamed, it can erode through the dura, and you've got a spinal fluid leak. Okay? So there are a lot of people who think they've got good health, and they wake up one day and got terrible headaches, can't get out of bed, they're dizzy, they find out I got a spinal fluid leak, and they wonder why. The arachnoid membrane is involved. Okay? So you have that. Now, let me tell you another interesting thing about symptoms. People who have adhesive arachnoiditis or maybe they have some other disease involving the spine. But if you have a defect in the lumbar sacral arachnoid membrane, guess what? You're going to have headaches. Why? That membrane's connected. Their little fibers are connected. So if you have any defect in that membrane, it's going to affect up here in the head. Okay? And you're going to have headaches from time to time. You may also have some dizziness and what have you. So we've always wondered, you're supposed to have a back problem. How come you have headaches? Well, we now know. We now know. Now, there's a couple of other things that I want to bring to your attention now that are terribly critical. It has been a belief for a long time that the arachnoid membrane did protect the brain to some extent from getting some infections, bacterial infections like Neisseria meningitis. Okay. But without the blood supply, we now know it is a haven for virus infections. Okay. Viruses don't like blood. Viruses don't like to hibernate, infiltrate, or develop in tissues to develop cancer or pain or nerve degeneration with blood. So blood supply is what keeps viruses from getting into such organs as the heart and the kidney, even the liver. An organ that has a lot of blood supply, viruses don't like to get into. They can't. The blood pushes them out, not the arachnoid. So we now have growing evidence that the viruses, Epstein-Barr virus is the main one, but there's others, herpes 6, cytomegaloviruses, paraviruses, perhaps COVID, that like to hide out in the arachnoid membrane. And that we now realize is a very important concept. So you'll hear more. You've heard a lot about it already, but you're going to hear more and more about a concept that a disease outside the spinal cord can affect the arachnoid membrane inside the spinal canal. This is very true for such autoimmune diseases as lupus or psoriasis, Sjogren's, rheumatoid arthritis, or your viral autoimmune diseases such as Epstein-Barr. So it's the arachnoid membrane that is very susceptible to viral hibernation, if you will, or invasion and propagation. Now, lastly, and here's one here that has befuddled doctors, including myself, for a long time. I often wondered, how come people who have Guillain-Barré syndrome or Cauda-equina syndrome or adhesive arachnoiditis don't respond very good to prednisone, but they do real well to dexamethasone or methylprednisolone? Why? The arachnoiditis doesn't get its medications or nutrients through the blood. You've got to get that medication past the blood-brain barrier into the spinal fluid per se. And that only occurs with certain things. And there are two good examples I want to talk to you about here. One is the corticosteroids. Occasionally we'll see somebody who responds pretty well to prednisone. There's a new paper out on using prednisone for acute adhesive arachnoiditis. It's an excellent study, and high-dose prednisones work pretty well. But in the main, methylprednisolone, that's Bedrol, and dexamethasone are the only two corticosteroids that get into the spinal fluid so it'll coat the arachnoid membrane. Anti-inflammatories. None of the regular anti-inflammatories hardly work. For example, Motrin, what have you, they're not going to work. So you can go down to Walmart and buy all the NSAIDs on the counter, and you're not going to get much help from those because it doesn't get into the spinal fluid. They work great if you have a knee problem because those anti-inflammatories get into the knee joint or into the elbow joint, but they don't get into the spinal fluid. Ketorolac is the only one that consistently gets into the spinal fluid, and doctors don't like to use ketorolac because it's got some other problems with it, but it gets in and gets the job done. Diclofenac is the other anti-inflammatory that in most people does get into the spinal fluid and get some relief. So doctors who don't want to prescribe ketorolac, that's Toradol, diclofenac is your next choice. Those are the only two that work. However, there's a number of herbal products do. Interestingly enough, some of your natural herbal products, plant products, will get into the spinal fluid when these high-powered prescription drugs don't. So there's a growing group out there of people trying to identify agents that'll get into the spinal fluid. Well, let me wrap this up. Practically everybody who has intractable pain, practically everybody who suffers some kind of severe pain involving the spinal cord needs to be aware of the arachnoid membrane and needs to know the things I've talked about here, because I do want to close out with a bit of bad news. You cannot see arachnoiditis per se on the MRI. Okay, you can see it if it forms adhesions because it forms a mass, but it is so thin, it's a membrane. Now, if it gets thickened, you can see where that membrane is kind of a nice black line on the MRI, but you can't see that until it gets very far advanced. So we cannot take an MRI of the cervical spine or the lumbar spine and say for sure that that's arachnoiditis. If the cat develops adhesions, we can. So we have to be clinical about it. Eliminate everything else, and then you can kind of make that assumption. Now, what symptom are we talking about here? First off, when you get arachnoiditis, that pain stays kind of in one spot. It doesn't radiate. Pain radiates into the legs or the buttocks only when it gets into the cauda-equina nerve roots. If the pain is just in the arachnoid membrane, it tends to stay right there, and you can do a lot of manipulation of the back, heating pads, and what have you, may not help much. So the pain stays quite constant in one place. That's kind of the hallmark of arachnoiditis, particularly of the cervical spine. So anyway, spread the word a little bit. The knowledge of what the arachnoid membrane is and does is critical to understanding pain and disability. And it's new information, but we're going to make good use of it. I want to move on now to the next part of the show. One of the things, and one of the reasons why I personally want to keep doing this show, is that I am of the opinion that the American public, including the body politic, has been fed so much propaganda for so long that they have a very poor opinion of pain patients, opioids, benzodiazepines, pain doctors. I mean, pain is almost a four-letter word, and it's impeding us of getting our payments to help people. It's impeding us to get doctors to want to do into it. Residents or graduating medical students who want to go into pain management is down 45%. In other words, doctors don't want to treat it anymore. In other words, I think we've got a heck of a problem here because everybody, they think ill of us. They don't think we're legitimate. We're going to talk a lot more about this. And I don't think this just happened last week. This has been coming for some time. Now, Jamie, you read something to me earlier today that I thought was dynamite, and I want you to read that in total because I think it's as good a description of what's happened in the public's eye as anything I've heard. Take it away.
Yes, sir. Thank you. This was from a Kelly Lawler in CPP News Source Public Edition, found on Facebook. It says, as a society, we've become so terrified of addiction that we've become numb to the opposite condition, untreated agony. We've swallowed the lie that anyone who uses opioids is just one step away from the gutter. And because of that lie, we've allowed our neighbors, people in wheelchairs, people recovering from surgery, people with incurable diseases to be interrogated, second guessed, and left behind. We treat overdoses with compassion, but we treat chronic pain with suspicion. Ask yourself, why? The war on opioids was supposed to end exploitation. Instead, it's creating a new one, a slow, bureaucratic form of abandonment done not in alleys or back rooms, but in waiting rooms and denial letters.
Very good. Very good. In other words, that's what, to some extent, what we're going to do on this show, what we can to overcome what you just heard. I mean, people who are ill deserve decency, respect, obviously, much less good humanitarian care. Yet the people down on the street who are homeless, using drugs down there and overdose, have great sympathy. Okay? Give us your personal belief on what deception or fraudulent information has been thrust upon the public to bring us to this point. We're ready to close out. Let me wrap up here for a moment. We're going to continue this show every week and try to help organize the fight against what you've just heard. We're going to try what we can in different ways. On my end, I'm going to keep working to try to find some treatments for the underlying causes so people won't need so many opioids. Number two, we're going to hope we get a little education out there about how to get along with fewer opioids. And number three, we're going to continue up our advocacy on trying to change the perception of pain patients and of opioids, and above all, to get a society who recognizes travesty, sickness, illness, suffering, and end-of-life care. So that's our three things we're going to keep doing. With that, thank you so much, everyone. Keep up the great work, and we'll see you next week. Good night.